and welcome to another Pipe of Pearl. Today's Pearl, we're going to look at epistaxis. So just starting with a few facts about epistaxis, it's one of those ones that transcends from primary healthcare into the emergency department, and it's actually one of the most common ENT emergencies in both of those areas. Now there's two broad types of epistaxis. We have the anterior one, which luckily constitutes 90% of all cases, and posterior, which is 10% of all cases that present to either primary healthcare or the emergency department. Now, the unfortunate thing is public opinion on nosebleeds is that they're quite mundane. They don't really need to worry about them. 60% of the population has had a nosebleed at some stage in their life, and they fixed it themselves. So it's very common for people not to consider nosebleeds bad enough to go to the emergency department or call an ambulance or even present to an outpatients department for it, even though some of them can result in pretty life-threatening situations. Now, as far as actually dying from a nosebleed, the numbers are pretty stacked in the favor of survivability. They did a study that showed that of the 2.4 million presentations that presented to the US, 4 people died as a result of nosebleeds or complications thereafter. So pretty good odds of saving the person's life when dealing with epistaxis. Now, only 10% of all nosebleeds that ever happen warrant medical intervention. Okay, so for all the nosebleeds that are happening in the world, only around 10% of those will actually need medical intervention. So if they're coming to you and you need to intervene, it's a rare one. It's not a nosebleed, so don't think of epistaxis that presents to you as a standard nosebleed. Okay, always have your little feelers up that it could be one of the bad ones. Now, they're most common in ages between kids that are between 2 and 10, and then you have a break, and then when you're 50 to 80, you have more probability of getting a nosebleed. And 85% of all presenting epistaxis, so the ones that present, so that in that 10%, actually have no found cause of why they happened. Investigations are done, they've had a nosebleed, but there's no actual reason for that nosebleed to occur. So if you can't find the reason, don't beat yourself up. It's actually quite normal. Now, looking at a bit of pathophysiology behind nosebleeds, there's a few common causes that can generally be broken up into local, systemic, environmental, and then medications that we'll look at more closely. So the common local causes is people picking their nose, people who have a deviated septum, which makes them more prevalent to having nosebleeds, the obvious trauma, and then the chronic use of any nasal cannulas, that sort of thing. The systemic reasons are a little bit more complicated, like things like alcoholism and that profound vasodilatory response that's caused by alcohol and the weakening of the vessels. We have hypertension, we have all forms of vascular malformation, and you also have a bunch of different coagulopathies that can occur, like von Willebrand's, hemophilia, stuff like that. Environmental ones are quite interesting. It branches from allergies, things like chronic allergic reactions and localized allergic reactions around the ENT can make you more susceptible to nosebleeds. And then you've got environmental areas that are quite dry. So it's far more common in winter months because the moisture in the air just gets sucked away. In any really dry environments, you'll find a lot of kids mostly will get your epistaxis. Now, as far as what happens, obviously a nosebleed is caused by the rupture of blood vessels within the nasal mucosa. Now, the rupturing can be spontaneous or initiated by trauma or one of the other causes that we spoke about. An increase in patients' blood pressure can increase the length of the episode. So it can cause it, but it also makes it a lot worse. So for patients on antihypertensives and they're not taking them and get a nosebleed, they're often quite difficult to control, as to anticoagulant medications. Now, luckily for us, most nosebleeds occur in the anterior part of the nose, a place called the Kesselbach's plexus, which has luckily been called our Little's area. Now, this is where a whole bunch of vessels, 5 different arteries will actually branch in together into this region that forms in the soft part of the nose, making it quite a common area for what's known as your anterior epistaxis. Now, if you're unfortunate enough to have a bleed from the posterior or superior naval cavity, then that's often just called a posterior nosebleed, and it's usually assumed that it's due to bleeding within an area called the Woodruff plexus. Now, these are often difficult to control and are associated with bleeding from both nostrils. Okay, so instead of having bleeding from one side within these littles area, they actually have bleeding that occurs at the back of the septum, and it's big enough that it will flow over the top of the septum and come down both sides. Okay, it's also associated with rolling down the back of the throat into the pharynx, and a sign that people show is they'll actually start coughing up blood and swallowing blood, and it looks like hemoptysis itself. Now, this can generate a greater blood flow into the posterior pharynx, which has a higher risk of your nasal compromise, and it also means that they're ingesting a bunch of blood, which the stomach doesn't like, so they end up causing vomiting, which obviously increases the chances of airway compromise itself. So when you get a case of epistaxis walk into the room, it's one of those weird ones that you don't start with the event, you start with the initial treatment. Now, believe it or not, some people actually get the positioning of where to pinch wrong. I was surprised when I read it myself as well, but if someone walks into you or you're presented with a patient that has epistaxis and it's uncontrolled and the person's showing signs of shock, they're cold, clammy looking, high heart rate, that sort of thing, then you skip everything. You treat it as a medical emergency and you go straight to anterior packing. So you do your normal catastrophic hemorrhage, if you will, protocols, and you go straight to anterior packing. Now, if they're not in shock, then you start with pinching the soft part of the nose, okay, as shown in picture Bravo. Okay, pinch the soft part of the nose, 5, 10, sometimes 15 minutes. Just get them to hold it. If they don't want to hold it, there's a few ways that you can rig up pincers with tongue depressors and that sort of thing, but I'll let you get inventive and look it up yourself. But you need to pinch the nose and hold it full time. Don't let them take it off to have a look, just hold it for that whole duration. Some people recommend, some protocols as well, recommend using ice on the bridge of the nose, the back of the neck. Can help, assume that it causes vasoconstriction in the area. There's weak evidence of it, but it doesn't do any harm. So if you have it, sure, knock yourself out. Now, whilst you're holding this nose, you can utilize the time to start your EPSAM or your subjective information and even obtain vital signs from the patients to see if you missed those early signs of shock index itself. So when looking at the EPSAM and the subjective data, we obviously get the event, we find out what's happened. Some people will just say, I don't know, it just started, and that usually brings to environmental. But if there's picking, blowing, injury, illness, that sort of thing, it can put us down a line of basically finding the causality to why they have a nosebleed. History can be important. Mostly we see if people suffer from chronic nosebleeds, find out if they've got any current medical or family history of bleeding disorders and hypertension. There's the big ones to look for. When we move into our subjective finding, we need to know how long it's been going on for, how often it occurs, and what the severity is of this. So get them to estimate how much blood they've lost. I've already soaked through 27 tissues, that sort of thing, compared to, oh no, this is the first tissue I've used. It's a big difference. Now, when we move to the allergies and medication parts, as mentioned, hay fever and nasal irritation from allergies can be a cause of epistaxis. And certain medications are known to bring on bleeding disorders and epistaxis itself. So the use of NSAIDs, especially a mixture of two, people often fall into the trap of using ibuprofen and Voltaren gel. Now that mix in particular is very good at causing antiplatelet and affecting the COX enzyme, which obviously brings on bleeding disorders. We have our anticoagulants, which is easy and obvious to understand. But then we also have the overuse of topical nasal steroid sprays, and that can actually degrade the thickness of the mucosa, making you more susceptible to nosebleed. Natural therapies that are linked to bleeding disorders is too much vitamin E, ginkgo, and ginseed. And then obviously, if people are taking cocaine, then it's a strong link with nosebleeds itself. Once the EPSAN's done, you can start moving into your objective findings. Now, there's a little bit of a caveat here is you can obviously do your vital signs whilst you're doing that initial treatment, but then you stop. Now, if your direct pressure has stopped it, then there's no reason to move on to any objective investigations. Okay, if they're no longer bleeding, there's nothing else to find. But if your direct pressure hasn't stopped, then you move on to objective findings if they're not in shock. If they're in shock, you just go straight on to anterior packing. If they're not in shock, then you can start looking at what's causing it. So you have to remove the clot initially before you can have a look and before you can spray any surface spray. So you remove the clot by gently blowing the nose or using suction, whatever you've got. Then you spray lignocaine and phenylephrine, which will aid in the visualization. Then the idea is you want to have a look in the area to see if you can see any bleed from one of the vessels. So you check the Little's area for any bleed. Now, if there's bleeding, good, you go straight to anterior packing and it's more likely to work. Now, if you can't see any bleed, you still start with anterior packing, but knowing yourself that you may have one of those rare ones that needs further treatment and further packing or even posterior technique, and you should really up the ante for evacuation if you're in one of those situations. So the point of having a look in the nose is if you see an area in the Little's area bleeding, then you have a high probability of fixing this yourself with anterior packing that we'll go through. If you don't, you may have missed it, or it may be a posterior bleed, especially if it's coupled with coughing up blood, that sort of thing, which may mean you need to escalate it and potentially look at techniques like posterior packing. And that forms part of your assessment. So just know that 95% of all the presentations that come to you can be controlled with good compressions alone. Now, if it can't, then you have one of those complex ones. Okay, and there's nothing wrong with considering evacuation higher care in that case the direct pressure doesn't stop, because anterior packing, posterior packing, and treatments that come thereafter can be difficult to control even in a hospital environment and can involve the use of ENTs to actually control the bleed. Okay, so if you're stuck in the field or in a little outpatients department, okay, you may be ill-equipped to deal with it. Let's move on to treatment and our plan. So if we decide to do anterior packing, then a device known as a rapid rhino is absolutely best. Now, if you don't have a rapid rhino, then it's just more indication that you probably should evacuate this patient to an area where they can get better care. But things you can do prior to, or even during the evacuation, is if you get gauze ribbon and soak it in Vaseline. That technique has been used for many years, well before rhino rapids were invented. Now the idea is you get the ribbon gauze and you fold it in half, soak it in Vaseline, and then you stick it through so you have both ends of the gauze sticking out to make it a lot easier to take it out. Now if that doesn't work, then you really have to upgrade to the rhino. Okay, now if it doesn't work and you have used a rhino, then you need to move into the prospects of posterior packing. Now that's where you use an extended rapid rhino, or you use a follow catheter. Now it may seem pretty easy to do when you're reading about it, but it's one of those ones that's best done in a facility as opposed to in the bush. Now, obviously, if you're stuck in a situation and you need to do posterior packing, then you can do it, but just take your time doing it. Make sure it's in the right position before you inflate it, and discuss the prospect of using saline instead of air, because air tends to leak and then you release it and just brings back that bleed. Okay, so it's pretty much all we'll discuss about the packing side of the house. Now, if you are successful in your management, then we go on to further treatment points. So if it gets controlled by direct pressure alone, then the person can go back to work or they can go home, as long as there's nothing remarkable in your findings. Okay, they haven't lost a significant amount of blood, all those sorts of things. Now you can take them home with topical steroid cream and petroleum jelly, and they can use it for 6 weeks post, and that can known to prevent 94% of cases actually prevent any reoccurrence as well. It creates a good barrier that protects those arteries. Now, any complex case needs following up. So if it's out of the normal, there's no trauma associated with it, you can't really find the cause, someone's having reoccurring nosebleeds, then it needs follow-up and further investigation. Now, if you use anterior or posterior packing, then they really should receive prophylactic antibiotics. Now, that can be given by you if you're stuck with the patient in a situation, just with a phone call, or it needs to be part of the handover that you've done anterior packing once it gets back to a clinic. There are some cases that patients will be released home with anterior packing in place, and that comes with specific education. However, in our environment, it is highly unlikely that you'll pack somebody in the field or in the outpatients department and then send them home. Okay, especially if you follow the flowchart that we're about to go through, because epistaxis is a spectrum of very easy treatment all the way up to being quite difficult. Okay, so we start with a patient presenting, as we just discussed. Now, if this patient, assumingly it's uncontrolled, that's why they're there, and they're in shock, we ignore everything we just mentioned about subjective and objective data, and we go straight to emergency management and straight to anterior packing. Okay, because they're already lost too much blood. They're already subject to blood loss, which is just going to be harder for you to control. Okay, so emergency management can use the use of systemic TXA, things like that as well, that you'd do for any other bleed. That's the sort of stuff you'd do. Okay, 2 cannulas, oxygen if needed, all that sort of stuff. Okay, oxygen can be difficult, obviously, because you need access to the nose, but just put a Hudson over the mouth area and it can work. It's not the best, but it can help. The use of TXA on rhino rapids and on soaking it in your gourds has been explored in the past with mixed results. Okay, mixed results. So some study says it works quite well as part of the repertoire, using it in this advanced area. Others say it's really no different than just using packing itself. So see what happens in your own facility from there. Okay, but once you've done the anterior packing, always be aware that you may have to upgrade to posterior packing, and they should move on to that higher level of care and maybe even hospitalization. Now, if your patient comes in and they're not in shock, then you can go through your initial treatment with direct pressure. If that stops it, then you can most likely send them away with education and some simple treatment. If that direct pressure for 10-15 minutes hasn't stopped it, then you go through your observation. You use lignocaine and phenylephrine to numb the area for one, cause vasoconstriction, and have an observation to see if it's anterior or likely posterior. Move on to anterior packing, and the same treatment applies thereafter. Okay, so that finishes the Pearl on epistaxis. Hope you got something out of it. Granted, it's one of those ones that it is pre-hospital, mostly because patients rock up because they don't consider it an emergency, but most protocols out there put it as an emergency CPG. So just be aware that even though you're in a pre-hospital environment, emergencies can happen, and you'll have to escalate and transfer from a pre-hospital focus into an emergency focus in order to better support the patient. But until next time, take care.